What I wanted to focus today is the interaction that us as radiologists have with artificial intelligence and prostate cancer imaging, really from detection of prostate cancer to the clinical integration of our tools. I'll start by a statement just to really set my vision there. I know it's difficult because AI's change, and change comes with so many difficulties, barriers, challenges, doubts. However, it's nothing more beautiful than embracing the change because this is key to progress. And with it, we unlock amazing opportunities to move forward and progress. And not just for us, this is for our patients. A little bit of background of what are the real problems that we are facing now. We have in the UK a really shortage of radiologists, of clinical radiology consultants. And this is not just the UK, all over Europe and also in the US, there is a shortage of the workforce. Without further action, this shortfall is going to really increase by another 10% by 2028. And of course, this is going to continue increase. It goes on the contrary, we have an increase in the rate of the CT and MRI scans in the same time frame by another 10%, by 10%, 11%, 10% average. So it's really this balance that we really need to address, and we really need to address now. And I think AI is a solution, not just the AI, the way we interact and implement AI. Another angle, the reporting demand is growing faster than the workforce. And this is important. And it's not another problem, it's another angle of looking at it. Looking at it not just from the radiologist point of view, but actually from the system point of view, from the management point of view. 7 out of 10 clinical directors that they were surveyed said there were not enough radiologists to deliver the safe and effective care to patients. We exist as a profession to deliver good care to our patients. And all of the clinical directors were concerned about the impact of the workforce in the morale and burnout of our staff. Now, burnout and the low morale translates into not perfect patient care. Everything is linked to each other. So, on the other hand, the increase in prostate cancer globally, it's also a big problem. And this is going to continue to increase. You see the figures here, the number of men dying with prostate cancer more than double worldwide, not just the UK scenario here, over the next 2 decades, from 1.4 million in 2020 to almost 3 million in 2040. And this is still huge. More men will also die from the condition because we still have a late detection of prostate cancer. An estimated 700,000 men dying by 2040 compared to half of it in 2020. So it's becoming a real problem, the prostate cancer, which we need to address, and we really have to overcome the shortage of radiologists and also this increased accidents. So how can we do it? Well, our helper, AI. But we really need to interact with AI in a very meaningful way. We need to look at it in 2 areas, 2 major areas: efficiency improvement and increased health. Both of them ultimately impact the patient care. So the improving efficiency is not about saving time, it's also delivering that faster and more reliable diagnosis, which will impact on the quality of care we actually give to our patients. So if we look at the prostate cancer diagnostic pathway, where the MRI is actually used now, you can see we use it as for risk stratification for pre-biopsy. Of course, we have the calculator, the MRI, and the urinary blood test. But also on this high-risk patient, we do it prior to the biopsy. So these 2 MRIs. But if we actually think about why, well, because the MRI reduces the number of patients undergoing biopsy, so it has a rule-out role, reduces diagnosis of indolent disease, and in the same time, it has a major rule-out role because increased detection of high-grade prostate cancer prior to negative biopsy in the biopsy-naive patients. And of course, improves determination of tumor grade and volume that comes with it. Really, the MRI had this success with the diffusion weighted imaging. This is a T2 weighted images. It's difficult to say there is a tumor here. Probably someone with experience, they would say, well, this is abnormal on the apex here on the right. However, diffusion has completely changed the scenario, and we have done some work here, we and the others, into really incorporating diffusion, not just in detection, but also in the prediction of the AI score of actually a probability of being a cancer. So let's take a step back. There are a fair amount of evidence now that the MRI has a role in prostate cancer screening. Now, we cannot really MRI everyone, every patient comes to the door, so there's evidence building up there that probably a risk-based pathway would be probably the most intelligent one, always having in mind that MRI is part of it. Okay? And we are now building level 3, 4, and 5 evidence, which means diagnostic thinking, therapy impact, and also patient outcome impact with our studies. This is an overview of all the screening studies where MRI is part of. And if I may just highlight 2 screening studies, not being able, in interest of time, to highlight all of them, the Stockholm 3 study, and what this study showed, or the trial, what this showed is that by introducing MRI in the strategy, which included MRI targeted biopsies, you'd see a biopsy rate reduced by 37%. There was no difference on detection of ugly tumors, grade 2, but it was a significant reduction on grade 1 tumors, group grade 1 tumors, that the ones that are actually indolent. And this is really what we need with our screening tools, because we don't want to overdiagnose. This is another study, which is not a trial, but nevertheless very nicely done, of over 2,000 men randomly selected for a screening with the MRI and PSA. What I want to highlight from this study, it's the last bullet point here. 2 in 3 men with a positive screening MRI had a PSA of less than 3, which is the norm, right? PSA less than 3 is normal. So this, it didn't prove, but it did just sort of put out there the fact that prostate MRI may have a value in screening independently that of PSA. So you really have to work together and get a strategy, a screening strategy, which definitely includes MRI. What is very important is really you need a test which does more good than harm. So you really have to play a little bit and sort of like a good conduct of the orchestra between the PSA and the pirates. Of course, what you want to do, you want to have a lower biopsy rate with the high cancer detection rates. You really want to be on that sort of left upper quadrant here. So you want to push the PSA, let's say, down the level, so more than 1, but then we really have to be good at being accurate at scoring pirates 4 and 5. And in fact, this is where the AI comes. So AI not only maintains the high sensitivity, but can also increase the specificity to achieve the goal. A little bit of what is there beyond imaging. I think what we have to see a holistic pathway where the AI goes across the pathway of the patient, as it is seen in this diagram, all the way to patient management, because without having this global overview, really the potential of AI is not fully achieved or used. But for the rest of this presentation, I'm going to focus on these 2 parts here: the role of MRI in automatic detection and pirate scoring using machine learning, so the role of AI in MRI, and also automatic gland and lesion segmentation to help biopsy. And then I'm going to give a little bit of a glimpse of what it could do on treatment impact. So let's start with image quality. And this is something now that the new scanners have it embedded, the deep learning reconstruction of low quality images, but more rapidly acquire data, reducing noise and the scan time. So basically you can see here, without deep learning, it's 4 minutes for this T2 weighted images. With deep learning, you have it. And again, you improve the quality And this is really down to the mapping of undersampled case-based data to fully sampled images. So you increase the image contrast with at the same time you suppress the noise. And of course, the system does automatically detect and correct the motion artifact. So this is really embedded in the scanner. This because we always start with image quality, garbage in, garbage out. If the images are not of good quality, then of course the AI is not going to perform the way it should. A little bit here on increasing the increase the resolution for purpose of stage detection, but again, it's all one package. Again, deep learning reconstruction here. You can see how beautiful this image down at the top bottom on the right, at the bottom on the right, you can see very nice depiction of the capsule here. You can confidently say if there is evidence or not of capsule extension. In terms of image quality, I want to highlight a very nice paper here, and the message I want to give is that there is efforts now being put in place for an automatic AI-based scoring of image quality. So as the image, the patient, the scanner will tell you if you need to, for example, edit the CMRI, if you want to repeat a sequence. So what you get is actually optimized for delivering a correct diagnosis. So how can we, as human radiologists, interact with AI? Well, in many ways, actually. And I draw your attention to this very, very nice paper from Anwar Padani and Nicholas Papanikolaou on the ways we interact with the AI. And depending on your scenario, there are various ways, and you don't have to interact only one way. You can actually combine the ways you interact. It can be a decision support tool. In my everyday clinical practice, I use it as an additional reader, as an assisted target review, as a triage. And what I mean with triage, a triage of your list, the workflow, not the triage of patient yet. And of course, as a high confidence filtering. I don't think we've reached the point yet for the moment where the AI, at least on this topic, can be a standalone. We still work to be done. And of course, everything you do, your tool has to be backed by data and by publication, by real world data. And this is to show that the AI, the Pi, it's actually non-inferior to a radiologist, but a radiologist with the experience and MDT or tumor board prostate radiology. You can see the sensitivity and specificity here, which is comparable. The dedicated AI tool that matches the performance of such a radiologist, actually, it's important, but also what I want to add, it generalizes in multiple sizes scanners, because this is really key. It has to work for different manufacturers and for various strengths and for various populations. This is just a little bit more detailed work here, and I think what is important to realize, actually, we have to really start integrating patient data, not just the images per se, or the contribution from imaging, but also the PSA density, the PIRADS, and more data streams you integrate using AI, you have an increase in specificity now, which is very important compared to the PIRADS alone. So not only you maintain the sensitivity, but you can see the specificity is shooting out up to 0.92 compared to in the 70s before, without integration. The other thing to keep in mind, very important, for the same cancer detection rate, you have far less, fewer biopsies. This is very important because you don't want to have biopsies of benign tissue or indolent tumors. So a little bit on triage. So this is what Pi does. You get to your workstation, to your PACS workstation to report, and this is already been processed very quickly. And again, this is, of course, examples of prostate, but it is the same in real life when you can see the lesion, the cases being processed and have been processed. And then it's really easy to see even visually the ones that would require your attention immediately, the ones that AI think is significant tumor, and you can kind of triage the list that maybe later on you get to the ones that are not similar, there is no tumor there, or by vice versa, depending on when you're reporting. So it gives the flexibility to kind of triage your work case depending on your specific circumstances. Moving to the gallgland and tumor segmentation. Again, it gives you much more accurate tumor volume, which is very important when you calculate the PSA density, because depending on the density and if there is no lesion or not in the prostate gland, the pathway might be different. Patient might require a biopsy or not. So very important, the accurate volume estimation. And of course, lesions, especially in the anterior gland, can be missed if the biopsy is not targeted. Again, in this case, you have a lesion which is definitely very experienced with tumor, and these are pushed into the biopsy device, so the biopsy is accurately done with a fusion biopsy targeting exact abnormality. Coming to the reports, I think it's very important to keep in mind that the reports not only have to serve our clinicians, but more importantly, they have to serve our patients. When you talk to the patient, explain, it has to be clear, concise, and visual, so the patient exactly knows what's going to happen to them, because they buy in, so everything, the whole pathway, it's more successful. Here, it's a lesion at the apex of the prostate, clearly seen in the T2, diffusion, ADC map, and contrast. This is the report. Then the lesion is actually painted or assigned in the map, and then the images are put in the report. And this is what you have in your hand. The patient doesn't want to see endless text. What they want to see, it's a visual graphics and the images, and say, okay, I know where the needle is going to go now. And this is really extremely important, the way we communicate with them. And of course, what is the next step? The next step is you really fuse the images with your ultrasound device, being that in the urology domain or in the radiology domain or in both, as work as a team. And this is exactly what we do here at Policlinico Gemelli in Rome. Then the accuracy of the target is also, of course, optimized. So you really go into the lesion. This is really immensely helpful. Rather than starting outlining again, the output of the eye is actually directly being sent to the fusion biopsy device. And of course, it goes beyond, because I think the ultimate role that the ultimate goal we want to achieve, it's actually an impact on the patient pathway. How can you make sure that actually we make an impact in their healthcare, not just on one step of their pathway? And again, here, this is an example that we really we're going to transform the way these patients are triaged in the NHS. Of course, we'll have a PSA test and a referral by GP, but if the MRI is done, a high score automatically triages those patients to radiologist, and then the same day or the next day biopsy is booked. So the 28-day pathway, which is the standard classic pathway, which is good for all, actually is now being personalized to, if you have a high risk lesion, you go through that pathway, and the biopsy is done immediately, and of course the results are immediately, or the time is shortened, so treatment can be delivered fast. On the other hand, if there is a low AS score, a rule-out disease, then that can be pushed to taking more time for radiologists to check it. And then, of course, if the radiologist sees a lesion, he can go to the biopsy. And there is more the system can do with the 3D contours for the biopsy, but also for planning the radiotherapy and surgery. And in fact, I just want to highlight a really nice paper that is maybe a few years back now, but we're working on really improving the ability of AI to predict presence of extracapsular extension, and especially sparing of the neurovascular bundle, which is very, very important. However, what we need to do, we need those AI systems to be integrated to drive real value. It's no point that you look at those systems, they're great, but then they don't work and they're not slick to use in a clinical practice, okay? You need all the stakeholders to buy into changing the pathway. We need to really have understandable, exportable, and usable output. And you need to take into account the whole ecosystem of the patient, the whole pathway. And that would make AI a trusted tool across the whole care journey of the patient. And this is really important to realize from the beginning. So work with all stakeholders, IT being an important one, because it will be then an important bottleneck if you don't. What is the future? Well, the future is definitely going to potentiate that multimodal AI. We are going to be transformed into not just radiologists, but super diagnosticians. And think of the orchestra that now does, a violin that plays on the other one. We are going to be conductors. We're going to kind of get all the information with the help of AI, and we're going to really deliver the beautiful music that is only been delivered by a good lead of the orchestra. I just want to thank a lot of collaborators everywhere, and you can see they're come from various parts. Surgeons, oncologists, scientists, really, and also the many institutions that funded my research. And thank you for all the 3 beautiful cities I've had the pleasure of working and living.
Okay, so now we will dip a bit more in deep of the clinical applications of AI, and this is taken from our institutional experience, where we integrated AI in we actually have a full AI-assisted diagnostic workflow, which starts from the acquisition, because as we saw, there is an AI application on the scanners, which allows to reduce the acquisition time, improve the quality, and correct the artifacts. But what I want to focus now is on the analysis and the reporting, which are assisted by AI. And so the first step is the triage, because with AI, we can have pre-analyzed all the prostate cases. So we imagine now to start reporting, and I can decide whether to prioritize the highly likely positive cases or negative cases. And this can be useful, at any time of the day, because when for example, I feel tired and I prefer to go through the likely negative ones, I can do it. Next, when I open a case, what is really useful actually, and makes me sparing a lot of time, is the volume calculation first, because what we used to do in our clinical practice is to calculate the prostate volume using the ellipsoid formula. But this is a bit time consuming, because it takes those 2, 3 to 5 minutes. And also, it may not be accurate in all cases. It's overall reported to be to overestimate the prostate volume by 10%. And there are the prostate, it's not always a perfect ellipsoid. So maybe, as in this case, the patient had a previous transurethral resection, and automatic volumetry would allow you to have an accurate volume calculation that you can't have with ellipsoid, where this part would be included in the prostate volume. And you can have also zonal segmentation, which can be helpful, for example, in pre-surgical setting for BPH. Of course, prostate volume is important when it comes to the PSA density calculation. And this is a case, the same prostate where the volume was calculated with ellipsoid formula and automatically. And we can see that there was, it's not that much, because it's 0.04 difference in PSA density, but when it comes close to the 0.15 cutoff of PSA density, it can be tricky, because if this patient has not a lesion, maybe a biopsy could be also recommended if the PSA density is high. And this is why it's very important to have an accurate volume calculation. In general, ellipsoid formula is reported to have a good accuracy, but of course it's influenced by the prostate morphology and the BPH. As we saw in the slide before, there was that large BPH nodule pushing on the bladder. It has good reproducibility, But overall, it tends to overestimate the prostate volume. On the other hand, the volumetry has excellent accuracy and reproducibility, excellent correlation with pathological findings. But if we do it, we don't do it manually because it would result in a very time-consuming task. And also, there is evidence that volumetry-derived PSA density has superior diagnostic performance for clinically significant cancers detection. Okay, and then let's come to the core part of our AI-assisted workflow, which is the lesion detection. I mean, it's the most thrilling challenge for us and for everyone working on like prostate imaging, and especially what we have our tool in the pre-biopsy setting is the PIRATES. So we stratify the risk of the patient having a clinically significant prostate cancer. And these rates are taken from a large meta-analysis where we see that actually we all know when we daily report prostate MRI that it's easy to identify 1 or 2 and also 4 and 5. The issue is when it comes to the PIRATES 3. PIRATES 3 because we can have 20% of clinically significant prostate cancers and let's say a significant amount of insignificant cancers. So the main, let's say, clinical need in prostate cancer detection is to reduce the PIRATES 3 rate, which is reported to be approximately around 20% in our activity, and this is also a quality assurance metric. And it's also it depends on image quality and reader experience. It is reported to be influenced by these two features. But there is also evidence that the case revision from a second reader can reduce the detection rate of PIRATES 3 by 37%, which means that if we ask a colleague to give a look at our PIRATES 3 scans, 1 out of 3 cases will be upgraded or downgraded to PIRATES 1 and 2 or 4 respectively. And so what if that colleague is AI? We will have now some example. For example, we start from our work list and go through a few cases. The first case is a 73-year-old man with a low PSA and a DRE positive on the right side. We have our multiparametric MRI lasting 15 minutes. And there is also here on the heat map, the AI says there is this lesion, which is, we would give a PIRATES 4 showing high signal intensity on IB value DWI, low signal intensity on ADC, and also early contrast enhancement, but this is a PIRATES 4. We integrate the findings in our report. This is the report generated at our institution with a sector map to guide the urologist for the biopsy. The biopsy was taken, and this was a Gleason score 4+3. Next case, this is a patient with a high PSA density, so a bit higher probability of having a pre-test probability of clinically significant prostate cancer, which actually wasn't missed because there is a clear evidence of marked diffusion restriction in the left PZ, but also there was another lesion on the right side, which is smaller. This is not that bright on IB value DWI, and it's not that hypointense on ADC. There is a bit of early enhancement, and this actually was detected by AI. So we have 2 lesions left and right peripheral zone, and they were both biopsied, and they were both clinically significant cancers. Okay, now we have another case, and this is a patient who was scanned before coming to our institution with a Pirates 4 in the left PZ, and he came for the MRI. AI said that there was no focal lesion here, and actually we also got that the target of the previous biopsy was this nodule in the left PZ, but this tiny nodule actually we can see it very well on T2 weighted images, and this is why high quality images can lower the Pirates 3 rate, because when we have good high quality T2 weighted images, we can see some inhomogeneity in this nodule, and it's like contact with TZ, which makes it an ectopic BPH. So we can reliably here exclude a suspicion for this patient, and we can avoid a biopsy when it's not necessary. And to do this, we also have the support of AI, which had already would have discharged this patient without doing the biopsy. This is a last example just to get what we said, and this was the case where AI actually detected 3 intermediate risk lesions, because it got a score between 3 and 3.2 out of 5. And the same patient, we gave the software low quality images and high quality images, and in the high quality images, there was actually no lesion detection, no focal lesion detected. And if we analyze the findings of the low quality images, we can see that the lesions detected are all in the TZ, and we know that the TZ is an organized chaos. With low quality, it can be more chaos than organized with low quality images, but with high quality images, we can organize that chaos, and also the AI detection is more reliable, which means that quality, however, always matters. Thank you for your attention.